In the next section, we're going to pick up where we left off with air in the alveoli and discuss diffusion as oxygen goes from the alveoli into the pulmonary capillary to be circulated throughout the body. The next section of our pulmonary pathophysiology review, we're going to talk about diffusion, basically how gases cross the alveolar capillary membrane. There's an equation we can use to describe this that's represented by Fick's law, shown on the screen. Now, you really don't need to memorize this equation, but let's think about the different components because they all make sense. You still need to memorize the alveolar gas equation, by the way. The amount of gas that's going to cross over a membrane per unit time is directly proportional to the diffusion coefficient of that gas, D. That's something that's going to be inherent to whatever gas is trying to diffuse. It's directly proportional to the surface area. If we have more surface area, more gas is going to diffuse across, obviously. It's also directly proportional to the partial pressure gradient. If there's a greater pressure gradient between the two sides of the membrane, more gas will diffuse across. And the volume of gas is inversely proportional to the thickness of the membrane. If it's a thicker membrane, less gas is going to diffuse across. All that makes sense. Now let's think about some of these things with reference to what's going on in the lung. The diffusion coefficient, or D, is a number that's inherent to the gas that's trying to diffuse across. It's set by nature. We can't really control it. Oxygen's got a diffusion coefficient. Carbon dioxide's got a diffusion coefficient. The surface area in our lungs is great. It's one of the reasons why we have this extensive branching and extensive alveolar capillary network. The pressure gradient for oxygen or for CO2 is fairly large. That also contributes to diffusion. Now, it's very important that the membrane thickness, which at times is going to be affected by pathological processes, will affect our diffusion. It will affect how much oxygen gets from the alveoli into the bloodstream. Remember, our alveolar surface area is about 70 to 75 meters squared, about the size of a tennis court. When we think about what contributes to the thickness of the membrane, there's a lot of different layers across which oxygen or carbon dioxide has to cross. There's a thin layer of fluid that lines the alveoli. Sometimes that can be increased in the cases of pulmonary edema. There's an alveolar epithelium, which is a flat squamous cell. There's an alveolar basement membrane. There's an interstitial space, which sometimes can be increased if there's fibrosis or inflammation within that interstitial space. There's a capillary basement membrane. There's a capillary endothelium, once again squamous and relatively flat. And there's a red blood cell membrane. All these different levels only are about 0.5 to 1 micron in the healthy lung. But if anything increases the size of these, they're going to serve to decrease the amount of oxygen that can diffuse into our lungs, diffuse from our lungs into the bloodstream. For oxygen, there's a good pressure gradient between alveolar O2 and pulmonary capillary O2 that helps contribute to diffusion. If alveolar O2 falls, there's going to be less of a pressure gradient and less oxygen will diffuse across. Carbon dioxide has a very, very high D, so carbon dioxide readily diffuses from the bloodstream into the capillary. Remember, carbon dioxide is going the other way. For that reason, ventilation is far more important to the removal of CO2. Diffusion doesn't limit the amount of CO2 you can get rid of. There's a third pulmonary function test that can measure how much oxygen can diffuse in. This is called the diffusion capacity for carbon monoxide, sometimes abbreviated DLCO. This is easy to do in that when we measure the amount of carbon monoxide inhaled and exhaled, we can look at the difference between the two of those and calculate how much was taken up by red blood cells. Carbon monoxide binds to hemoglobin in the same way that oxygen does. It's a reason why you don't want to go sucking on your tailpipe, because the carbon monoxide will displace the oxygen. And if you suck on your tailpipe enough, it could put you in trouble. When we do pulmonary function tests to measure diffusion capacity, we don't give you that much carbon monoxide. A normal value for diffusion capacity is about 25, but you really don't need to memorize this number at all. Diffusion capacity will always be reported out as a percent predicted, and that's what you need to look at. The diffusion capacity will increase actually as we exercise. As we exercise, more alveoli get perfused, more oxygen is going to diffuse across. Diffusion capacity will be decreased by certain pulmonary diseases, especially pulmonary fibrosis, that increases the thickness of the membrane across which oxygen's got to diffuse. Diffusion capacity will be increased in the case of pneumonia, when you might have pus in the airways or in the alveoli that would also inhibit the amount of oxygen that will diffuse across. Diffusion capacity is also decreased in emphysema, in which we've got less alveoli. DLCO reflects the diffusion out of the lungs and into the red blood cells. Hemoglobin will bind the oxygen or the carbon monoxide and helps maintain the pressure gradient. Anything that's going to increase our pulmonary blood volume will increase our diffusion capacity. Anything that will reduce the reaction rate with hemoglobin will reduce the diffusion capacity. Remember, to optimize diffusion, we've got a large surface area, we've got a thin interstitial membrane, and our blood volume and hemoglobin concentrations are perfect to maximize the amount of oxygen that can diffuse across. Things that will decrease our diffusion capacity. Alveolar destruction, as in the case of emphysema, will decrease the total surface area for gas exchange. The case of a pulmonary embolism, where we have an obstruction to blood flow and less perfused alveoli, will lead to a lower diffusion capacity. Anything that increases the thickness of the membrane across which the gas has to diffuse, such as pulmonary fibrosis, scar tissue, or pulmonary edema, transudative fluid, will decrease our diffusion capacity. Things that give us a low cardiac output, heart failure or volume depletion, will lower our diffusion capacity. And low hemoglobin, less molecules for the carbon monoxide or oxygen to bind to, will lower our diffusion capacity. Diffusion capacity is increased when we exercise. We're increasing our cardiac output, we're increasing the number of alveoli that are perfused. Polycythemia will increase our diffusion capacity. If we have more red blood cells around, more hemoglobin can take up the oxygen or carbon monoxide. The case of alveolar hemorrhage, where blood bleeds into the alveolar spaces and can act as a sink and take up a lot of carbon monoxide or oxygen. This actually won't help the patient functionally, but will make the diffusion capacity look higher. Let's do a question that tests this. A 45-year-old woman has scleroderma, and as a result of that, she has severe pulmonary fibrosis. She's on oxygen at baseline. What would we expect her pulmonary function test to show? If she has scleroderma and severe pulmonary fibrosis, we would expect her to have a restrictive lung disease. Therefore, we know her lung volumes, including her FRC, are going to be low. Therefore, we know the correct answer is either B or D. We can cross out A or C, where she'd have an increased functional residual capacity, or E, where she'd have a normal functional residual capacity. Remember, that fibrotic lung that she has is going to increase the elastic recoil tension on her lungs. It's going to lead to a lower FRC. Would you expect her diffusion capacity to be increased or decreased? If she has pulmonary fibrosis, scar tissue, and thickening of her membranes, we would expect her diffusion capacity to get worse. So the correct answer here is B. Her FRC would be low and her DLCO would be low. This is another example that Dr. Thwaites likes to put out. Scleroderma is a disease you might not have heard of, you might not have studied. But what this question is testing is what pulmonary fibrosis is going to do to your pulmonary function tests. You don't have to remember that scleroderma causes pulmonary fibrosis. There's plenty of time to learn that later on. Another question. Which of the following patients would we expect to have an increased diffusion capacity? Patient with emphysema, Patient with emphysema is going to have less alveoli, so they're going to have a lower diffusion capacity. Patient with polycythemia, that could be the right answer. Patient with pulmonary sarcoidosis. We might not know what pulmonary sarcoidosis is, but we do know it's a pulmonary disease that's generally going to lead to fibrosis. If the patient has fibrosis, we'd expect them to have a lower diffusion capacity. What about a patient with a heart attack? In general, a patient with a heart attack would have a lower cardiac output, and therefore their diffusion capacity would be lower. So the correct answer is the patient with polycythemia or a higher red blood cell count. Let's think about how much oxygen is dissolved in our blood. Henry's laws of gases in solution state that the amount of oxygen that will dissolve in your blood is a product of the solubility of oxygen. If the only oxygen we could carry in our blood was the amount that was dissolved, we couldn't carry that much oxygen. There needs to be another mechanism by which we carry oxygen. That other mechanism is hemoglobin. Oxygen binds to the hemoglobin molecule and changes the conformation from deoxyhemoglobin to oxyhemoglobin. The amount of oxygen you can bind is determined by the oxygen carrying capacity, and that's shown in this equation here. This is not an equation you need to memorize, but once again, let's think about it because it makes sense. The amount of hemoglobin you have times a constant, 1.34, times the saturation. When we talk about saturation, that refers to how much hemoglobin is oxyhemoglobin compared to deoxyhemoglobin. And it's actually the same thing that's measured by the finger clip with the little red light on it that you might see patients in the hospital have, the percent sat. The more hemoglobin you have, the higher percent sat, the more oxygen your blood is carrying. And this is a very important evolutionary step that allowed our blood to carry more oxygen. So the total amount of oxygen in the blood is the amount of oxygen that's bound to hemoglobin, plus a little bit that's dissolved in the blood as well. Bound hemoglobin is the most important term, and that's going to be dependent on the amount of hemoglobin we have that could be affected by anemia or polycythemia, but it's also going to be affected by the oxygen saturation. That concludes our discussion of diffusion. We're going to continue this discussion talking about how oxygen binds with hemoglobin to be transported throughout the body.